Hello, everyone. Welcome to our live interviews as part of our India Live 2024 conference. Today, I have been joined by Dr. James Spratt, who is a renowned interventional cardiologist based in the United Kingdom. He's also a part of the Optima PCI group, which is premium group which optimizes PCI and calcium management diseases. So welcome, Dr. James.
Pleasure to be here.
Yeah.
It's a really interesting, invigorating, innovative conference. Lovely to be here.
Thank you. So let's discuss about the management of calcified coronary disease. So in your opinion, right now in 2024, where are we? How good are we at managing calcium?
Yeah, I'll just take a step back if you don't mind, because I think the reason we're here is because as in Optima, we believe in the value of clarity of messaging. Right. We believe in the value of images, in analogies, in trying to connect real world problems to physician solutions. So calcium is a great example of that. It's been around a long time, but it's only recently we've started to talk about it. It's only recently we've started to look beneath the surface and try to understand this disease a little bit more and really get to grips with it. So it's always been a problem, but I think before the iceberg was beneath the water and we just ignored it because there wasn't much we could do about it. But now it seems like there's endless options. And I think physicians are asking different questions, not, how do I treat, but, where do I start? Where do I start with all this cornucopia of options?
Correct. So because as you told, we have a plethora of options available today. We have our intravascular lithotripsy. We have our good old rotablation. There are people who say one may not be enough and you do both. So in that case, how do you say, how do we decide on that?
Well, I think we believe very strongly in the value of systematic assessment. So there's no point in being random about these things. You start off with a clear assessment of what you're trying to achieve. What you're trying to achieve may change between the patient, the lesion, the clinical scenario. And I think a good place to start is always, what are the patient goals? How can I align my treatment with the patient goals? We all know instinctively that a 32-year-old patient is a very different animal to a 90-year-old patient. And again, a stable patient is very different to someone with ST elevation MI. So putting that all to aside for 1 second, a great place to start is with intravascular imaging. Right. That gives you the landscape of disease. It tells you where the plaque starts, where it finishes, the plaque morphology, and how hard the calcium is going to be to treat. Right. Ironically, we're at a stage now where concentric calcific disease is easier to treat because even our heart pressure balloons will expand concentrically. Right. But what's really tricky is eccentric disease or nodular disease, where what you don't want to do is risk overexpansion of the soft part of the artery and risk perforation. So that's where the newer therapies are coming into their own, really. As you correctly say, rotational atherectomy has been around for 30 years now. In certain scenarios, it's great technology, but we have to accept the fact the penetration of this technology is still not great. It's still in the range of 5%. So 95% of physicians and patients aren't getting access to this therapy, and that's probably because it's tricky. And we're certainly narrowing that gap with lithotripsy, which is much more intuitive to use.
It's pretty easier to use.
We may not understand it, or at least some of us may not understand it, but at the same time, it seems like a balloon. Yeah. We know it's actually delivering therapy, but at the same time, it's instinctive, it feels familiar, and it's going to open up a whole new avenue of calcium management.
Right. Coming back to the point of morphology of calcium, talking about protruding calcium, do you treat an eruptive nodule differently from a non-eruptive nodule, and does your management change when you see either of them? How do you strategize?
So first things first, an eruptive nodule is usually in the context of an acute coronary syndrome. So we know that the biology is active. There's much more likely to be thrombus there. The patient may be clinically unstable. But actually, on a lesion level, there's also instability. It's erupted, if you like. It's already fractured. So in terms of improving the vessel area, that's actually easier. The problem is we know that that's not enough often for these patients. In 2 years' time, they come back to haunt us.
Correct.
Whereas by contrast, the calcific nodules, which have the fibrous cap, can be much more difficult to treat. But if you do manage to debulk them and fracture them and expand the lumen enough to implant a stent, these patients do well. So it's a kind of a dichotomy, if you like.
Right.
On day one, you think you've done a great job with the eruptive nodule, but actually that patient may come back if we're not careful.
Right. So what about the debate regarding the efficacy of IVL in a nodular calcium? I think recently Dr. Ziad Ali, they showed a lot of data from their Disrupted CAD study that IVL worked well in both eruptive as well as non-eruptive nodules. But there are a lot of people who say that because it's a nodular calcium, you probably need an atherectomy kind of a device to shave it, and that may give better results. When we're talking about eruptive calcium, what do you think? Because there's all this debate going around that IVL is not that effective, although we have data from the Disrupted CAD. Dr. Ziad Ali has shown at many places that IVL works equally effective in calcified as well as eruptive as well as non-eruptive nodule. What do you do in your clinical practice? Do you go for an IVL or prefer an atherectomy?
So it sort of depends on what your goal is. If you think about it just conceptually, what you're trying to do is enlarge the lumen enough to put a stent in.
Right.
So the problem with eruptive nodules is that the nodule takes up a volume. So you want to reduce the volume and compress the calcium by fracturing it. So it's very rare that it's a one-size-fits-all strategy. And it's also rare that a nodule occurs in isolation. It normally occurs within the context of quite a lot of calcium. So I would say that our ablative technologies are good at volume reduction when you haven't got wire bias. In other words, when the lesions are tight. When the lesions are less tight, it's less effective. I think with IVL, for most nodules, it does pretty well. The areas where it may struggle is when it's a very dense, very thick nodule. And unfortunately, it's quite difficult to tell those nodules ahead of treatment because even with imaging, you can't see deep to the calcium.
It's true.
So it may well be that combination therapy of so-called shave and shock may be the way forward.
How often do you do that in your clinical practice, shave and shock?
I would say at the moment, probably our centre at St George's in London has got the biggest experience of lithotripsy in the world.
Right.
So we do quite a lot of lithotripsy. I would say of the subset of shave and shock, it's probably in the region of 15 to 20%.
Right. Nice. Another important thing is, even though we always promote that imaging is so important in our clinical practice, but still if we see all the data around and all the large randomized trials that have been conducted, the penetrance of imaging is still pretty low. So what is your message to people that how should we improve upon it?
Well, imaging should be simple, but remember, it's actionable information. There's no magic sauce with putting an IVUS catheter or an OCT catheter down the artery. You have to be able to interpret the images and then act on those images. If you don't act on what you're seeing, you're not going to get the results. And I think actually we've seen from the data, it's increasingly convincingly an argument that imaging adds value to patients. But to get to that next level, it's going to need widespread adoption. And for widespread adoption, it needs to be simplified and clarified, which is one of the reasons why we partnered with Boston to introduce the IVUS 123, which I think will simplify things quite a bit.
Right. Thank you so much, Dr. James, for joining us.
Yeah, thanks for the interview. Very nice to chat to you.
Thank you, everyone. Let's see you around at India Live.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.